right, good afternoon, everyone, and actually good morning to our colleagues joining us from the Pacific Coast. We are so thrilled to be joined today by a panel of presenters who will be focusing their efforts on highlighting DCD cases in the pediatric population. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure, of course, to kick off today's program. Now, as always, before I turn it over to our moderator who will be facilitating today's discussion, I'd like to briefly review some keynotes and reminders regarding today's presentation. Now, for those of you who are newer to our Lab Advancement series and may be joining us for the very first time today, we ask that you take note of the Q&A box that's located at the very bottom of your Zoom navigation bar. All of your questions for our presenters should be submitted here. Now, for those of you who may have submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our speakers address them throughout the course of the presentation. Now, should you have any additional questions, please feel free to submit them in that Q&A box. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, additionally, for those of you who may be joining us as a group, we ask that you take note of this poll that I'm about to launch right now. If you are able to, please just complete this poll to indicate approximately how many people have joined us from your group. The results will ultimately help us and our presenters gauge a level of participation and engagement in today's program. Now, for anyone interested in our upcoming webinars, please note that registration is currently open for our next transplant-focused webinar, which will focus on identifying nutrition risks and applying them to patient care. You can tune in for that on March 25th at 3 p.m. Eastern. Additionally, registration is currently open for our very first innovation-focused webinar of the year. Given the past year and the overall impact of COVID, this webinar will highlight successful workforce models for transplant centers, OPOs, and hospitals in a virtual environment. We encourage you to join us for that on March 30th at 2 p.m. Eastern. Now, for more information on either program and to stay up to date on all of our upcoming programs, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we are offering 1 CEP-C credit and 1 nursing contact hour as a result of your participation. Additionally, there is a certificate of attendance that will be available for those of you who are seeking CEs that are not being offered. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you an opportunity to provide us with your valuable feedback. If you happen to be listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and formally introduce our moderator for today's program, Cynthia Hacker, OPO Community Education Manager at the Life Alliance Organ Recovery Agency. Cynthia, thank you so much for joining us today. And at this point, I'll go ahead and turn the floor over to you.
Thank you, Deanna, and welcome everybody. I would like to just go over the order of presentations and what the presenters will be covering. First, Dr. Hatem will be covering the OPO perspective of pediatric DCD cases, authorization, family support, and procurement. Dr. Perez will be covering the pediatric transplantation of liver utilization, highlighting. Dr. Miloh will be covering pediatric transplant liver utilization, highlighting pediatric DCD outcomes and waitlist mortality. And as far as each presenter and their bios, Dr. Louay Hatem is our medical director at Life Alliance Organ Recovery Agency. Dr. Hatem graduated from the School of Medicine at the University of Damascus, Sarai in 2001. He completed a master's degree in cardiac thoracic surgery and intensive care unit management in 2008. Since then, he has performed hundreds of open heart surgeries. Dr. Hatem joined Leora in 2015, first as a surgical coordinator, and in April 2018 as an organ recovery surgeon. In August 2020, he was promoted to the position of medical director. Dr. Hatem is enthusiastic, humble, honest, and honorable person, eager to contribute to team success through his arduous work, attention to details, and continuous learning. Our next presenter, Dr. Perez, is the chief of the Division of Transplantation in the Department of Surgery at the University of California, Davis Medical Center, where he has been a faculty member for close to 30 years. He has led the transplant program, which has successfully expanded the pool of kidney available for transplantation and has consistently been a national leader in the volume of deceased donor kidney transplants annually. Dr. Perez has been a longtime advocate of organ donation locally and nationally, participating in many public awareness and educational activities. He has served on the advisory board for the regional organ procurement organization, CIRAR Donor Services, as well as several committees, and on the board of directors of the United Network for Organ Sharing. Our next presenter is Dr. Miloh, who joins us as the Director of Pediatric Liver Transplant Medicine at the Miami Transplant Institute, a unique alliation between Jackson Health System and UHealth University of Miami Health System. Dr. Miloh is actively involved in the clinical investigation of various pediatric liver disease, such as primary sclerosing autoimmune hepatitis, Williamson disease, metabolic diseases, biliary atresia, non-alkyl fatty liver diseases, and acute liver failure. He has special interest in increasing children's access to transplant, improving patients' adherence, and transition of care to adult providers. He completed his residency in pediatrics at St. Christopher's Hospital for Children in Philadelphia, with subsequent fellowship training in pediatric gastroenterology, hepatology, and liver transplant at Mount Sinai Hospital in New York. I would like to now turn this back over to Deanna for her to continue.
I'm actually going to go ahead and turn it over to Dr. Hatem, who's going to kick off today's program. Dr. Hatem, you may be on mute.
Okay, good afternoon. Can you hear me now?
Good.
Okay, thank you for having me today, for the opportunity. I'm going to be talking about the donation, pediatric donation after circulatory arrest from the OPO perspective. So pediatric donation after cardiac death or circulatory death is an established pathway for organ donation. However, it remains a relative rare event worldwide. And outside the pediatric ICU, it is unfamiliar. Most pediatrician and healthcare provider are unfamiliar with it. The goal of this presentation is to introduce the process and the concept of pediatric DCD. So we're going to be talking about describe the OPO and the donor hospital roles in the DCD process, and differentiate or mention a little bit of the differences between a DCD with adult donor versus pediatric donor. A recent large study found that only 21% of children that dying in the ICU were declared brain dead, and that up to 70% of children dying in the ICU, they die following withdrawal of life support. Despite that, only 8% of pediatric donation happen through DCD. That tells us how this is a rare, uncommon event. The potential benefits of this practice to patients on the waiting list are well known. So increasing donor pool, making more organ available. But what I want to point to also is the donation can be also an opportunity to honor the patients or the donor family. It can give them, can help the family with the grieving process, can give them a sense of legacy for their loved one, that he been able to be a hero saving lives through organ donation. So it not only has a positive effect on recipients, but also the family of the donor will have most of the time have a very positive effect on them. Okay, we'll talk a little bit about the difference between the donation after brain death versus the donation after circulatory arrest. The majority of donation, of especially pediatric donation, happen through donation after brain death, which is, as I mentioned, is like almost a 92% of donation in pediatric happen after brain death. In those cases, the patient is declared dead in the ICU through well-known established neurologic criteria. There's an apnea test, there's a CBF brain flow, which is like in this image, we can see, this is an angiogram for the brain. It shows here, the first image is a normal flow. The second image, there's no flow to the brain, which indicate a brain death. This is in contrast with a DCD, where the DCD happen after a family decide to withdraw life support. And after that, the discussion of donation and the consent will be taken from the family, and the pronunciation of death will happen in the OR. Offering the possibility of donation require careful attention to ethical principles to ensure that conflict of interest are avoided and that the family is free to make an independent, fully informed decision. Doing so allow family and the decision maker to decide if donation is something they wish to incorporate into end-of-life care. Again, one of the most important difference between donation after brain death and donation after circulatory arrest is the timing of death. In brain death, the pronunciation of death gonna happen first in the ICU, then the discussion with the family, getting consent, and then we go to the OR for recovery. And in donation in DCD, the family will make end-of-life decision, and then the discussion of donation will happen. We'll go to the OR, the withdrawal of life support can happen in the OR, the pronunciation of death happen in the OR. So talking about donation before declaration of death is somehow much more difficult on family and also on healthcare provider. So after the withdrawal of care, after the family decide that they're gonna withdraw care, the family is approached regarding of possibility of donation, and the process will start with withdrawal of life support, which should happen the same way as it happened regularly without the incidence of donation. Each hospital has their own policy and their own practice how to withdraw care. The only difference is the withdrawal of life support gonna happen inside the OR most of the time. Sometime in an area close to the OR, but most of the hospital will have that withdrawal inside the OR. The only other difference that we'll give heparin to the patient before extubation. After that, the patient will go through a period of hypoxia. It's gonna lead to circulatory arrest, and to determine death, a period of 2 to 5 minutes with absent circulation has to be confirmed. And the time is also dependent on the hospital policy. After this time, organ recovery will start immediately. And here there's a time pressure between the withdrawal of care or the extubation and the starting of the recovery. This time, the organs are low perfused, and that's what we call the warm ischemic time. And we have to do all what is possible to reduce this time. And most centers have time limit between 30 to 120 minutes, depend on the organ. That after that, if the patient the heart does not stop in this time limit, the patient will go back to ICU or hospice or whatever is with the hospital to continue care, and he will not be able to be a donor. Here, gonna talk about what is the OPO responsibility and what's the hospital responsibility in the DCD. So the OPO will engage the family for authorization and will provide support for the family and the hospital staff, will recover the organ, package, and transport the organs to transplant centers. The hospital donors, they're responsible for managing the patient and write the orders, withdraw life support, administer of medication, declare the death, and care of the patient if not expire on time. In any circumstances, the OPO will not have any interfere with the dying process. They will not interfere with the decision of withdrawal of life support, the process of dying, the comfort measure, the extubation, all that. The OPO has nothing to do with that. That all will be done by the hospital, by their own policy. So in pediatric DCD, there's a couple challenges. First is the decision making. The withdrawal of life support is a difficult decision always, especially when it's a child. It's a tragic event. The family gonna be in a very difficult situation, and to mention the donation, it's also make it more difficult. Another factor that there is no registration here with the adult donor. Most of the adult donor are registered donor, so we just go and we tell the family that he's registered, and most of the time they want to honor his wish. But unfortunately, this is not the instance in pediatric, so that will make the decision much more harder for the family. And we notice from our practice that the family, in the case of children, the family almost always want to be present in the OR. This will create another challenge. You want to respect the family wishes to be in the OR to say their final goodbye, but the family has to be escorted out of the OR as soon as cardiac arrest happen, so will not delay the recovery process not to increase the warm ischemic time. I'm sorry. The other challenge is the organ size. So with pediatric, allocation of organs, it's much more challenging than adult. It's much more difficult to find a recipient with the right size and with the matching ABO and the HLA, with the also the close distance to the hospital. So the size of the organ is another challenge, and there are limitations regarding allocation and transplantation of specific organ based on size. It is important to note that in average, more organs are recovered from pediatric branded donor than a DCD. Additionally, the vast majority of DCD organ recovered are liver and kidneys. there are still challenges with the thoracic organs, the lung and the heart. One of them are not the ex vivo machine, the pump machine that used to pump the heart and the lung from the time of recovery to transplantation are not available in small sizes to accommodate pediatric donors. Some ethical issue to consider with the process. Some critics of the pediatric DCD practice say that either the OPO or pro-donation healthcare professional may influence parents to order to pursue withdrawal flight support for the purpose of organ donation. While this risk may exist, all professional society that have examined this issue have determined that ethical safeguards can be created to mitigate this risk. The first consideration when examining the risk to compare the DCD process to a routine withdrawal. Withdrawal decisions are difficult, but they are a regular part of pediatric critical care. As I mentioned, the death after withdrawal of life support is very common pathway for dying in the PICU, up to 70%. So once a decision are finalized, clinical are bound to apply the same principle and prioritize best interests of their patient and their family when considering donation possibilities. So the decision of pursue withdrawal must not be influenced by donation potential and should be proceed according to the same accepted medical practice. Healthcare professional must respect the dignity of the dying process throughout the whole process. And the discussion of the donation should respect the belief and the value of the family. Of course, also the OPO and the transplant center should not approach the family and have any contact with the family before the finalization of the withdrawal decision. So the only time we approach or we talk to the family before that is when a family member mentioned donation and they want to ask about it before they make the decision. Healthcare professionals should be allowed to freely object to participation in pediatric DCD. This is another issue. We see some health professional, they have certain belief and they don't want to participate in the process. We should allow them not to participate and ask whoever wanna find somebody else who's willing and who want to participate in the process. So also withdrawal of life support should be based on established ICU or hospital practice, policy and guideline, as I said before. The critical care team must be responsible for the patient management between the decision of withdrawal and determination of death. And the OPO and the transplant center has nothing to do with this. The OPO, organ recovery transplant team, must not be involved in any aspect of management of the dying process. And the organ recovery team should not be physically present in the OR until the determination of death has been completed. So the process happens, we bring the patient to the OR, we prep and drape, and the recovery team exit the OR. Then the hospital, pronouncing physician, will extubate, will bring the family, extubate, and wait until declaration. When the patient is declared dead, the family is escorted out of the OR and the surgical team will come in and do the recovery. challenges and obstacles. We talk about a little bit of this. I think that there's a need to increase the hospital staff and community awareness about the importance of donation and the option of pediatric DCD. There's a lot of even healthcare professionals that they're not aware that this is an option for a child to donate after cardiac death. There's the mistrust of the medical establishment and concern that the donor body be properly cared for. Again, the tragedy for the family is something beyond the only thing that we can offer is compassion and support to the family. And as I mentioned, most of the family find a relief in the donation. Allocation and transplantation, as I mentioned, finding a matching size is a challenging. Most of the organ donated are liver and kidneys. And this is a picture of a bloc kidney recovered from a 5 months old, were prepared in bloc and placed on the pump. We placing kidneys on the pump here in our OPO. Again, this is the aorta, both renal arteries. This is the inferior vena cava. And as I said, this was a 5 months old DCD, and those kidneys were transplanted in one of our local transplant centers. Thank you very much.
Our next presenter is Dr. Perez.
Well, good afternoon or morning, wherever you may be. I thank the Alliance for giving me the opportunity to talk about something that I feel very passionately about. And let's see, I have no financial disclosures. So here's what I hope to cover over the next 15 minutes. What is the problem we're trying to solve? What's the national experience with pediatric DCD donors? Why should we transplant pediatric kidneys? What are the barriers? What strategies should we use? Which patients should receive them? What are the most recent outcomes? And summary. So what's the problem that we're trying to solve? It's a little different than the other pediatric organs because, as was mentioned, size and age matching is important for the thoracic organs and liver, but for kidneys, it's not so. First of all, there is a crisis in our country with almost 100,000 patients on the waiting list, over 100,000, but 90,000 of those are on the kidney list, with 98% of them being adults. The average waiting time is 5 years, over 5 years, and over the past decade, over 90,000 patients have died before they could get transplanted or they were delisted because they were too sick. So for kids, I don't want to underestimate the problem with children, but the reality is there are fewer children on the wait list. As you can see, a little over 1,000 versus almost 90,000 adults. And by and large, kids have access to kidney transplantation. Living donation is still preferred. We always encourage that. But even if they don't have a living donor, there is a deceased donor allocation system in place that gives priority to children. It minimizes the wait time for those in need of transplantation because these children need a functioning kidney for normal growth and maturation. And then the highest quality adult kidneys are allocated to the pediatric recipients. So different from the adults, there's a relatively low rate of pediatric waitlist mortality for kidneys. So the question is, what's the national experience with DCD donation? It hasn't been very good. This is a recent publication this year, which talks about the national experience over the past or over 15 years from 2000 to 2015. So during that time, there was a lot of effort being made to promote pediatric DCD donation. As was mentioned by Dr. Hatem, some hospitals or ICUs, there's a lack of awareness that DCD donation is even a possibility for especially the young infants. So you can see here in the early part of the 2000s, a very low rate of DCD donation. In 2007, there was a Joint Commission mandate that all hospitals had to have DCD protocols for children, and there was a modest but significant increase, still less than 200 in the whole country per year. So that's not a very large experience. And when you look at the actual donors, pediatric kidney donors, they're usually young adolescents. The average is 11 to 12 in both brain death and circulatory death. So if you want to look more specifically at donation after circulatory death, this is an older paper, but really the data hasn't changed. Again, this is the national experience over 10 years, 2000 to 2009. And during that 10-year experience, a total of 12,000 pediatric kidneys recovered. Only 700, so that's less than 80 per year, were pediatric DCD. And when you look at the less than 5-year-old age group, less than 90 for the whole decade. So that's less than 10 per year. Again, this is national experience. So the question is there an opportunity there? And why should we do this? Why should we use pediatric kidneys? Well, they're very healthy kidneys that do very well. And when you look at the long-term outcomes of these pediatric kidneys and compare them to adults, as was done here, this is an old paper, but they had long follow-up, 78 on-bloc kidneys over a, looks like a 20-year period. And you can see here the pediatric kidneys, they had an early drop-off in graft survival over the first couple of years, but once they got going, they didn't stop, and you can see this. Whereas these older adult kidneys, you can see they had a gradual decrease in graft survival. As we know, this is the case for all adult kidneys, whether it's deceased donor or living donor, they have a gradual decrease in graft survival over years. In fact, a paper came out suggesting that these small pediatric en bloc kidneys are superior to even living donor kidneys. So why did they say that? Well, again, when you look at the long-term function of these pediatric kidneys, at 6 months, you have a GFR that's very much the same as a live donor. It's a little higher, but each year as the kidneys grow, you can see there's an increase in GFR up to 5 years here. And at 8 years, it's still higher than at the beginning. Whereas with the living donor kidney, the best adult kidney you can get, you have a significant decrease in GFR over time. This is very typical. So it's a very compelling reason to try to do these pediatric kidneys. So why don't we do more of them? What are the barriers? Well, they're tough to work with. They have a higher rate of early failure with thrombosis due to low flow, very vasoactive vessels. particularly the DCD with a rapid aortic exposure and cannulation. There's been shown to be a higher rate of injury, mechanical injury, whether it's a direct laceration, but more commonly it's a pulsion injury to the vessels that stretches and injures the endothelium. They don't flush as well because the kidneys are so vasoconstrictive. So there's a higher rate of primary non-function in the setting of DCD and a higher rate of urologic complications as noted there. So there are many disincentives then for not procuring these. Now, this is another national study which shows the somewhat tragic experience of the country. When you look at small pediatric donors, less than 8 kilos, in this study over 10 years, 431 donors, so a total of 862 kidneys, 480 or over half of them were not even recovered. And these are donors that already have the consent. Kidneys were left in place. Of those that were recovered, 145 were discarded for various reasons. So of the 862, less than a third or 27% were transplanted. So that to me looks like a significant opportunity for intervention. So how much is that opportunity? That's been studied many times. This is looking at ICU, a neonatal ICU. This is the Loma Linda neonatal ICU, and they looked at their experience, their protocol, their deaths in their ICU, and they concluded that their ICU and most level 3 ICUs would have on the average of 2 to 4 deceased donor kidney, DCD donor kidneys in their ICU per year. So when you extrapolate that, they projected that if all these NICUs, neonatal ICUs, had appropriate protocols, in the state of California, 120 kidneys could be available for transplantation per year, and nationally, 1,100 kidneys per year. So all of these kidneys, and we've already shown that these kidneys, if they work well, they're very good for a long time. So another NICU paper, this is from Utah, and what they found was that their utilization was very low compared to the potential for kidney. And they found a sobering 10%, fewer than 10% were referred appropriately into the OPO, and most of the referrals came after the death. So what strategies can we use then to overcome these obstacles? Over the past few years, our center and various other centers have developed specific strategies to address these challenges that I've mentioned. We have outlined this on a somewhat outdated but still relevant YouTube video. Just go UC Davis, Pediatric en bloc, renal transplant, and it'll come up. In 5 years, we have 1,300 reviews, and we're trying to get in double digits with thumbs up. So please put a thumbs up. What it goes and talks about is our whole strategy, which includes, as was mentioned before, pumping of the kidneys. We put them on a different type of pump. We published that in 2009. But there are several reasons for them. The kidneys, as mentioned before, they don't flush as well as adult kidneys because of the amount of vasoconstriction. After pumping, they clear up and resistance goes down. It facilitates the working of the backbench preparation, and it gives us an idea of kidney quality as well. So we pump almost all of the pediatric kidneys that we do. I won't really talk much about the different surgical techniques. Suffice it to say that we prefer to put our kidneys on the left side, standard aortic and vena cava anastomosis and 2 separate ureter anastomosis in the bladder. We try to immunosuppress them to avoid the need to biopsy these small kidneys. So we give them thymoglobulin for 5 doses, steroid free so that the kidneys can grow because we know steroid inhibits the growth. And then others have looked at agents to protect these kidneys from hyperfiltration injury. Here's a study that looked at ACE inhibitors, which decrease the perfusion pressure in the kidneys and possibly protects them from hyperfiltration injury. This is the study that they showed that the ones that were treated with ACE inhibition had better graft survival than those that weren't. So which patients should receive these kidneys? As mentioned before, they can go into either pediatric or adults. So with 90,000 patients on the adult list, there's plenty of opportunities to utilize these kidneys. We usually take small, low weight recipients, low immunologic risk, because we don't want to have them have a rejection episode. The same reason we don't put them in patients who have a high risk for recurrent disease because of the need for biopsies. They need to have a good bladder because of the risk of thrombosis, no hypercoagulable state. And then the patient needs to have a good understanding of the somewhat longer recovery period that they're in store for and adequate support. So we have put them in both adults and children. This is a publication about 6-7 years ago where we looked at our pediatric experience of on-bloc kidneys into pediatric recipients. They're usually young adolescents or older school-age kids. As you can see here, the median weight was 4 to 22 kilos. The kidneys grew with time and there were no early graft losses. And this has been looked at more recently by our nephrologists here, where they look at the national database, again, over a long period of time. This was 13 years. The question was, can you put these small pediatric on-bloc kidneys into children? And how do they do compared to a standard adult donor? And the answer to that question is they did very well. They did comparably well. As you can see here, the survival curves are the same. The number of on-bloc kidneys, though, as you can see, is very low, only 126 over a 13-year period compared to almost 7,000. So that raises the question, should we be putting more of these pediatric donor kidneys into pediatric recipients? And here's another reason why we should consider that. When you looked at graft function, as I mentioned before, these pediatric on-bloc kidneys, when they're placed in children, they have a GFR early at 6 months, that's 80, which is similar to adults. But when you look at 1 year and 5 year, the pediatric on-bloc kidney function continues to increase in GFR as the kidneys grow, whereas the adult kidneys decrease in GFR as the adult kidneys age, as unfortunately all adults and adult kidneys do. So you can see the big difference here in graft function. So what about the most recent outcomes? There are centers that are doing this. I'm just looking at 2 recent publications because of the shortness of this presentation, but there are others, but they're usually small centers. This is the recent publication that came out of the UK in Leeds, where they looked at infant and neonatal kidneys ranging down into the 1 week of age. They put them on pump. Sounds like they do it very similar to the Miami group. As here, you can see the unflushed kidneys before pumping and after, big difference. And here's the outcome. They had a early graft loss, but it leveled off. 86% 1 year compared to 93% when they were greater than 5 kilos. So 15 less than 5 kilos, 15 greater than 5 kilos. We've had a long experience with this over the last, we've done it for since the early 2000s, but here's our experience since the last 10 years. We've done 327, with the majority of these, as you can see, less than 10 kilos. And as you can see, the curve for the less than 10 kilos has a sharper graft loss early on, but once they get past that first year, they just keep on keeping on. And this is all kidneys less than 20 kilo donors. And lastly, we did publish our DCD experience a couple years ago, where we looked at less than 10 kilos DCD experience. We had 65 of them compared to 65 brain death, and essentially no difference, brain death versus DCD, whether it was censored or death censored or uncensored. And then, much as this recurring theme that they start out slow, but they just keep growing. And as you can see, kidney function continues to improve up to between 3 to 5 years, where your GFR now is now over 100, which is much better than the adult kidneys. So, and then in terms of our overall experience with pediatric donors at our institutions, this is all pediatric donors less than 17. So 503 recipients, you can see most of them are brain death, 324, whereas we have 179 deceased DCD, but you can see excellent long-term survival, both DCD and brain death. So that would lead me to conclude that we should be doing more of these, that we should be doing more pediatric DCD donors. It's possible, it's underutilized. The word needs to be spread. There's definitely an early price to pay, more surgical complications and early graft failure with the very small donors in particular, but renal function improves gradually over 2 to 3 years. Excellent long-term results. So what are the opportunities for improvement? Many. Better donor selection by looking at clinical and pump parameters, possibly. There needs to be an allocation policy to minimize cold ischemia time so that these pediatric kidneys can be transported to centers that are willing to do them. Intense education efforts, both in the PEDS ICU, but more particularly in the neonatal ICUs. Ongoing improvement in surgical techniques, both the donor and the recipient. And then, as I mentioned before, consideration for allocation of these pediatric kidneys to pediatric recipients. Right now, they're not even being offered them because the KDPI of these small kidneys is higher, usually higher than 50%, and the pediatric recipients are allocated the low KDPI kidneys. There's always improvement for early post-op management, and then improved preservation. That's sort of an interest of ours here. The standard preservation for these pediatric kidneys is cold, either static or perfusion, but we think there's a place for the warm perfusion now that's being employed for the thoracic organs and the liver, where you're perfusing it with an oxygenated blood-based solution. It'll give you a better opportunity to assess these kidneys and potentially transplant them. So thank you very much again for the opportunity, and I look forward to the question and answer session.
We have no Q&As in the Q&A section at this time. There were some questions mentioned during registration, and I'll be happy to share those with the presenter. How to maximize knowledge of pediatric transplant centers that will accept DCD organs.
We actually have one more presentation from Dr. Miloh.
Oh, sorry about that. I thought he went.
Okay, so hello everybody. Good afternoon, good morning, and thank you for allowing me to share the experience with liver donation in pediatrics after circulatory death. And do I have control? Okay. So liver transplant is primarily performed for congenital disorders such as biliary atresia, and second for metabolic disease. And you can see about 15% of transplants are done for acute liver failure and then other indications. Children are listed differently than adults. I mean, they're listed with a status 1A, which is similar to adults, but we have status 1B, which are patients with hepatoblastoma, which is a pediatric form of liver cancer, where you really are limited with time because you're giving chemotherapy and you want to transplant them relatively earlier. Children with metabolic liver disease who can have metabolic crises over the time and are just listed with a lower score. And there's acute and chronic liver disease. So your natural PELT score has to be above 25 and you have to be either intubated, receiving blood on dialysis, or with a low Glasgow Coma scale. So children younger than 12 are listed with a PELD score, pediatric end-stage liver disease, which includes the INR, bilirubin, albumin, but also growth failure and age less than 1. And children above 12 years of age receive the MELD score. Many children, receive the standard exception through their diagnosis. However, often the calculated MELD or PELD does not really reflect the acuity of disease, and the score is being appealed. So you can see that within a year, about 600 kids are added to the wait list. The highest group on the wait list are status 1A or B. The highest group, the age group, are children less than 11, but you can see that there are significant additions of the different ages. And in particular, if we're looking at the risk of a pre-transplant mortality, meaning mortality on the wait list, we can see that the most vulnerable group are the children younger than 1, where it's difficult to find a size match organ for them. And other factors that are associated with increased mortality on the wait list, besides the younger age, as you can see here, are also the MELD and the PELD score. The sicker they are, the more likely they are to die while waiting on the wait list. And if you compare biliary atresia, which is the most common indication for transplant, to other chronic liver diseases, you can see that actually the survival of children with biliary atresia is superior. So other diagnoses have a higher likelihood of death on the wait list. And in this table that summarizes the risk of mortality besides biliary atresia and the PELD, you can see that if there was no exception requested, then the hazard ratio is 1.8, meaning they're more likely to die if an exception is not requested. And you can also see that the smaller they are in height and weight, and the renal function also reflects the risk of mortality on the wait list. So how do we keep these children alive? What are means to decrease the waitlist mortality? So diagnose the patients as early as possible, either through neonatal screening or with the first visits with the pediatricians, having access to care, which becomes a political issue, health literacy and psychosocial support, because a lot of the children come from unprivileged families who don't have necessarily insurance, early referral to a liver transplant center where we can list these kids earlier, medical management of the underlying disease. For instance, some genetic metabolic diseases, we could treat them earlier. Nutritional support is extremely important. So we're very aggressive when it comes to tube feeds, TPN, because as you've seen in the previous slide, malnutrition is significantly correlated to outcomes and death on the wait list. Medical management of any liver disease, such as varices with scope, ascites, and prophylactic antibiotics if they have recurrent infections. Now in the process of development, artificial liver supports. Waitlist management follow-up is always assessing if a child is too sick at this point to be listed. Appeal for exceptions, very important to get the kids higher on the wait list, and prioritize children because there's some countries in the world that the calculated score for children is being tripled, or any organ younger than 40 first goes to a pediatric patient. But from a surgical standpoint, then ways to decrease, you can see here that there's a significant variance in the percentage of centers who are using exceptions. And if you want to manage your wait list, it is very important that you appeal for these kids. But surgical ways to decrease waitlist mortality are definitely center acceptance of an organ. The more aggressive or liberal a center is in accepting organs, the less likely patients are to die. Using technical variant grafts, and not just whole grafts, but splitting, reduced size, using ABO incompatible donors, living donation, auxiliary grafts, using donors of increased risks, those who are hepatitis B or C positive donors, which is being, but definitely donors after circulatory death that I will focus on the next few slides. So overall, you can see that over time, there's an increase in utility of DCDs in liver transplant patients. And currently in adults, almost about 600 are utilized annually. But if you look at the number of pediatric transplants, you can see that we're talking about maybe 20 over a period of 7 years. So not that much. And again, there's a significant difference between the United States. Some centers or areas or regions are much more aggressive in accepting DCDs. So currently the allocation of a DCD goes by the distance from the donor hospital by nautical miles. And then you can see that there are smaller circles that go with patients who have a MELD or a PELD above 15. So more experience in adults, you can see that the data is a little bit ambiguous. Some reports say that there's a higher likelihood of both graft loss and mortality in DCD patients after liver transplantation. However, there are more recent reports in adults that have shown that there is actually no difference in patient or graft survival. The most dreaded complication after DCD in liver are the biliary complications. The ischemic cholangiopathy, bile leaks, extrahepatic biliary strictures, or combined. Some patients are more prone to develop hepatic artery thrombosis and have primary non-function. And here you can see the percentage comparing DCD recipients to DBD recipients, and you can see that at least on this series, there was no difference in the biliary complications after DCDs. We're going to see a few slides here. For time's sake, I will be a little quicker, that there is a big spectrum of different biliary disease that can develop after DCDs, starting from mild to moderate cholangiopathy up until very rapid progression of it. And this is where you can see through PTC, you can see the dreaded biliary and diffuse strictures and complications that could be either at the anastomotic site, non-anastomotic, be central or diffuse, and definitely lead. If you have biliary complications, then your likelihood of graft survival are definitely lower than if you did not have biliary complications. But interestingly, here you can see that the patient survival was not really affected, probably because these patients are being retransplanted. So how can we improve outcomes in DCDs? Definitely choose the best livers with DCDs. And the extended criteria are older livers, patients who have a high BMI, If the warm ischemia is more than 30 minutes, there won't be good livers. If there's significant macrostatosis or microstatosis in the liver, probably DCD would not be a good idea. The ones who are hepatitis B positive, if the mean arterial pressure in the donor is less than 60, more than 20 minutes after withdrawal of life support, there could be more ischemia and longer cold ischemia time. And in the recipient, we also want to choose them very, very carefully. So probably kids with, or patients with hepatitis C malignancy, retransplant, also patients with a high BMI, non-Caucasian, the ones that you need to do vascular reconstruction or poor cardiac and respiratory function would not be the best candidates to receive a DCD. What we try to do is to optimize the protocol and using a heparin on the donor and using warm machine perfusion to salvage the organ. And they've stratified the risk for DCD by low risk, and it also depends on the disease, moderate risk and high risk. So just again, for time's sake, this is patients who relatively have lower risk of receiving a DCD are patients with autoimmune or NASH, and patients with the highest risk are patients with HCC, hepatitis C, and alcoholic liver disease. The good news is we've gotten better over time. You can see that if you compare the eras, then the graft survival has definitely improved in the last years of receiving a DCD. In particular about kids, this is a case summary of 57 children who received a DCD, of which 54 were whole livers, 3 were lateral, left lateral segment. And overall, you can see that the recipient age was a little bit higher in DCD compared to DBDs. The BMIs were a little bit elevated, and their initial Melder-Pelt score was a little higher. But overall, only less than 0.5% of all pediatric transplants are DCDs relative to 4% in the adults. So definitely is being underutilized. And if you compare the recipients, you can see that the kids, again, were sicker. More DCDs were on mechanical support, ventilatory support, had portal vein thrombosis pre-transplant, and less previous surgeries. But this is probably the most important slide. If you look at the allograft survival over time, you can see that it is definitely comparable DCDs to DBDs. And when you look at graft survival, even the DCDs, although it was not statistically significant, had improved patient survival over 10 years. And what were the causes? I mean, if you compare the biliary complications or vascular complications, specifically in pediatrics, you don't see a significant difference between DCDs and DBDs. And if you look at the donor characteristics between pediatric and adult recipients, so naturally in pediatric, the donor age was lower and the BMI was lower, and the cold ischemia time was a little bit lower in the adult patients. And when you compare pediatric DCDs to adult DCDs, you can see that the pediatric survival is definitely superior to the adult survival following DCDs. And when you compare the pediatric to adult complications, you could see that there is a little more vascular thrombosis, but this is throughout all pediatric transplants, not just for DCDs. And you can see that children tended to have more acute rejections. And this is also true in general because their immune system is much more robust. And again, specifically for children, we've even gotten better over time. So to summarize, what are the take-home points? Definitely children die on the wait list for liver transplant. We need to identify the children at greatest risk and prioritize them on the transplant wait list. Optimize their medical management prior to transplant to reduce their mortality. Small organs are difficult to find, and we need to expand donation through technical variants. DCDs may be used in a subset of children, and there's comparable long-term both patient and graft survival. So the use of DCD in children should be strongly considered. And I'd be happy to take any questions.
I can't hear you, Deanna.
I'm so sorry about that. I was on mute. I just wanted to say thank you to Dr. Miloh and Dr. Perez and Dr. Hatem for such fantastic presentations. I do realize we are at the top of the hour, so I appreciate those who have stuck with us and hung on. I know we have a couple of questions that have come in the Q&A and that were received during the registration process. So provided that our presenters are willing to stay on with us for a few additional minutes, we'll go ahead and open up the floor for any questions. So does that work for all of our presenters?
Yes.
Fine with me.
Okay.
Yes.
Perfect. Thank you all so much. That said, I'll go ahead and transition the floor to the Q&A. Just as a reminder for those of you who may have questions, you can go ahead and submit them into that Q&A box. Again, we'll give as much time as we can to address your questions, but we're unable to address them all. We will be sure to follow up with you all via email. That said, I'll go ahead and turn it back to Cynthia to go ahead and facilitate the Q&A discussion. Thank you.
This question I think was addressed already by Dr. Perez, but I'll go ahead and share it again. From Katie Peterson, are the immediate graft losses after pediatric DCD kidney transplants mainly due to vascular complications?
So I can answer that. Yes, most of them are due to vascular thrombosis, mostly arterial. But there are some that are due to just primary non-function from hyperfiltration, where the kidney's perfusing, it just never recovers from the preservation injury.
Those are all the questions in the Q&A for now.
All right, well, that made that easy. Thank you, Cynthia. So without further ado, on behalf of the Alliance, I'd just like to thank all of our presenters once again for taking the time to join us today and putting together such insightful, informative presentations for us all today. We appreciate your time. And of course, Cynthia, thank you so much for your willingness to join us and help to facilitate today's discussion. We really appreciate all of your efforts here. And of course, to our participants, again, we thank you for your patience. We thank you for hanging on with us, and we look forward to seeing you in the future. Take care, everyone. Have a great day.
Thank you.
Thank you, everyone.